Thank you, Dr. Luai and Dr. Mohammed, for that introduction. So today I've been asked to talk to you, I've been invited to talk to you, and I thank you for the invitation. And in particular, I've been asked to talk to you about how to set up a resistant hypertension and therefore, or after that, a potential renal denervation clinic. So the referrals for this potential clinic will obviously come from your colleagues, usually from other departments. So the first step, obviously, is to educate your colleagues or just remind them about the data. So as Dr. Luai already has presented this slide, so as you can see, unfortunately, we're only achieving control in about 50% of our patients with hypertension, and 15% are resistant to drug therapy altogether. So this really highlights an unmet need for further management or to escalate therapy. The second thing when you're thinking about running such a program or a clinic is to stick to the inclusion criteria of the trial. Thereby you will benefit the patients that need it most. You would avoid complications, etc. So as Dr. Luai was talking to you about the Radiance Hypertension Trio trial, this is really the pivotal sham-controlled randomized controlled trial. And if you note, the inclusion criteria took patients with a seated office blood pressure of 140/90. You'll note that you had to have basically normal renal function. They had to be on 3 or more antihypertensives, and really they have to be good, adequate antihypertensives, not just any willy-nilly antihypertensive. And then they saw them again after a period of washout, after approximately a month, and they only included the patients if the daytime ambulatory blood pressure readings were above 135 systolic. In addition to this, they had to have suitable renal artery anatomy for the renal denervation procedure, which is done via CT angiography or MRA. And things like if they had renal artery stenosis, those patients were excluded. In addition, as Dr. Luai highlighted, you need to exclude secondary causes of hypertension. So you should do some labs for hyperthyroidism, pheochromocytoma, and urinary tests for Conn's and Cushing syndromes. Next, it's important to stick to the guidelines, and probably the biggest society of hypertension is the European Society of Hypertension, and their guidelines have a 2B recommendation for renal denervation. It is important to note in these guidelines that they suggest selection of patients should be done in a shared multidisciplinary team manner rather than doing it all by yourself. And the procedure should only really be performed in large volume experience centers. So in terms of the frequency of these clinics, probably when you're trying to set it up initially, probably monthly is all you're going to get in terms of volume. But once the volume increases, certainly you could think about weekly clinics. There should be an easy referral process for those patients to your clinic. So we have an electronic referral system, which I'm sure a lot of you have that. And you can build in a triaging system into that so that the appropriate patients are triaged into that clinic. I think you should be readily available to your colleagues for a phone call or maybe WhatsApp messages, and that way you can get the patients in there. And I think you should have a collegial relationship with your friends and colleagues in other departments, medical, renal, vascular, and maybe even primary healthcare centers. When you initially see the patients, I think it's very important to highlight the issue of compliance, as I'll show you in the next slide, and you've already seen it actually in the previous presentation. So you can see that one of the major reasons of not meeting your blood pressure target is non-compliance of medications. So this study here shows you or estimates that half of your patients will stop one, if not all of the medications within a year of you starting them. So I think educating about compliance is very important. Often I find actually those in the low socioeconomic group, you give them a 3-month prescription, they think, well, that medicine is only for 3 months, but of course that medicine is for lifelong, and that has to be highlighted to the patients. In addition to highlighting compliance with medications, you should stress the importance of lifestyle changes, exercise, weight loss, salt reduction, these kind of things. Once you have decided that a patient is for renal denervation, you should have easy access to your cath lab to do the procedure. Your allied medical professional should be educated on how to do the thing, and it should be a team approach in doing the procedure to maximize the benefit and reduce the complications. So what about our experience at our center in Rashid Hospital here in Dubai? So I'll just highlight a couple of cases, if you will indulge me. So the first case was a 41-year-old man. He's had hypertension for a very long time, around 15 years. He visits our clinic regularly for this problem. His blood pressure has basically remained uncontrolled for that entirety of 15 years. He's had numerous compliance issues due to intolerance of the medications, which pre-renal denervation included amlodipine 10, azilsartan, chlorthalidone 40-12.5, bisoprolol 10, dapagliflozin, moxonidine 400, spironolactone 25, and in addition to those, he has been on multiple other medications, which he's been intolerant to. In addition to this, he has pre-diabetes and he's obese because he doesn't exercise, unfortunately, and also he's had previous PCI. The 2 clinic visits prior to the denervation, he had systolic blood pressure above 160 millimeters of mercury. An ambulatory blood pressure monitor 6 months prior to the procedure showed very high systolic average of 176, diastolic 102, MAP of 125. He had renal artery imaging with MRA, which excluded renal artery stenosis and fibromuscular dysplasia. In terms of labs, his thyroid were normal, preserved renal function, sodium and potassium were normal, hemoglobin was normal, and there was no evidence of Cushing's or pheochromocytoma. So we went ahead and did the ultrasound renal denervation procedure. We gained access to the right femoral artery using ultrasound guidance. We used a 7 French RDC 55 centimeter guiding catheter, a BMW wire. Hemostasis was achieved using an exoceal closure device. And as you can see here, we performed 3 sonifications to the left renal artery using a 6 millimeter balloon. And as I was pointed out by Dr. Loy, it's important to do a shot, which you can see on your right-hand side, to make sure that you have the balloon is basically covering the whole of the renal artery, because if you don't have, although there's no direct delivery of energy to the endothelial wall, if you don't have that contact, that ultrasound will not be delivered to where it's needed. The pain was very minimal, which we managed with benzodiazepines and opiates. And we always try to deliver therapy only to the main renal artery, which I think was hinted at before, and not the distal branches or the ostia. Then we focused on the right renal artery, and also 3 sonifications were delivered using the same balloon, and the procedure was completed without any complications or major pain issues. Then we followed him up approximately 2 weeks after the procedure, and we noted a good drop in the systolic blood pressure. This was the office seated blood pressure of approximately 30 millimeters of mercury. He didn't have any symptoms. 2 months after the procedure, he was seen again, and we noticed that his systolic blood pressure had jumped back up to around 160. And what had happened was he thought the renal denervation was actually a cure for the hypertension. So he stopped some of his medications. So we re-educated him that it's not a cure, it's just an additional management step for his blood pressure. So we put him back on all his medications, and after about 3 months, his systolic blood pressure was, the drop wasn't as good as at 2 weeks, but there was still a significant drop of approximately 10 millimeters of mercury. Another quick case, 50-year-old lady, hypertensive for longer than the previous man, 20 years. She actually had 2 previous renal denervations using an alternate device, but her blood pressure was still uncontrolled. She was also had some symptoms, perhaps related to the hypertension of dizziness and palpitations. She was on similar medications to the previous patient. She was also diabetic, had dyslipidemia, and also had coronary artery disease. Her ambulatory blood pressures 3 months prior to the procedure were actually higher than the man, of around systolic 191 with a MAP of 134. She had a CT angiogram of renal arteries. She didn't have any evidence of renal artery stenosis or fibromuscular dysplasia. Labs were unremarkable, as were investigations for pheochromocytoma and Cushing's. So we started with her right renal artery, again, ultrasound guided right femoral. Can I just get maybe 1 minute? Thank you so much. This time we used an IM catheter rather than RDC, again short and 55 centimeter BMW wire. She also had a 6 millimeter balloon, and we were able to deliver 3 sonifications to this artery successfully with minimal pain, again benzodiazepines and opiates. On the left-hand side, we were only able to deliver 2 sonifications, and the reason for that was, as you'll note, the artery is relatively short, it's quite tortuous, and you'll see that there is early origin of the branches. And usually you aim for 2 to 3 anyway, so I think that was sufficient. Heart follow-up, I might need 1 more minute, I'm sorry. Heart follow-up was a lot better. So 2 weeks later, symptoms were better. 2 months later, she had an ambulatory blood pressure monitor, and she had a remarkable drop in her blood pressure, actually. So down from 190 to around 120. So that's an average drop of approximately 70 millimeters of mercury. And she herself measures her blood pressure at home and noted the drop. So accordingly, her medications were adjusted. So we halved the dose of the azilsartan chlorthalidone. Otherwise, everything was the same. And she was again seen about 2 months from the procedure, and she sustained that drop of the systolic blood pressure. So I think she really benefited from this procedure. So with that, I'll thank you for your attention.